This is a demonstration of the PSA Choice Decision Aid. This is for exclusive use during the clinical encounter between a patient and a clinician. Let's get started. This first screen invites the clinician to share the screen with the patient and review what will happen to 1,000 men like the patient when they decide to participate in a PSA screening program. This shows 1,000 men represented by each one of these icons. And as this graph shows, 800 of those men will be able to receive the PSA test and over the next 10 years have normal results. 200 of these men, represented by these two boxes, will have abnormal PSA tests, of which 125 will be false alarms. These individuals do not have prostate cancer. The other 75 will have prostate cancer. Now, it is important to highlight to the patient that outside of the program, without PSA testing, 4 men out of 1,000 will be destined to die from prostate cancer. This is without screening. With screening, 1 man will avoid that destiny and will not die from prostate cancer, while the other 3 will have their destiny intact, will still die of prostate cancer. It is important also to note that of the 75 individuals in whom cancer was identified, 25 will receive treatment and not experience complications for those treatments. But for 50 out of the 75, there will be the experience of complications of treatment for prostate cancer. One way of summarizing this, if patients are still unclear, is through this graph, which shows that out of 1,000 men screened, 200 will have abnormal tests, of which only 75 will be true cancers and the other 125 will be false alarm. Yet all abnormalities in the test will require repeat PSA testing, biopsies, medications, or other tests. It also repeats to the patient that while there were 4 people out of 1,000 destined to die from prostate cancer, the screening program essentially saves 1 life. And that summarizes the benefits of screening. The risks of screening are again listed here in case the numerical presentation limits the understanding about the potential concerns related to particularly false positive PSA tests. Now, it's important to highlight to the patient that not everyone is a candidate, not every man is a candidate for PSA testing. And the important consideration here is that it takes about 10 years, shown in this graph, it takes about 10 years to see the effect on mortality from prostate cancer from the screening procedure, such that after 10 years, you see this graph separating. That means that screening only works in men who are likely to live 10 years or more. Or in other words, men who are likely to live less than 10 years do not benefit from screening PSA. We have embedded here a table that allows the clinician and the patient to discuss whether this particular patient has a life expectancy of 10 years or less. And in one summary, a summary that one can draw from this table is that men over 70 who have multiple medical problems have an average life expectancy of less than 10 years and therefore are unlikely to benefit from PSA testing. The next step in this decision aid is to engage in the deliberation with the patient. Given what we've discussed with the patient, is this something that the patient would like to do? And if so, what matters to them? Is it avoiding cancer? Is it avoiding the treatment complications that plagues 50 out of the 75 patients in which cancer will be identified? Are there any other important features that are critical for this patient? Perhaps survival until an important event in their life. It also is important to reflect with the patient, how does this fit with their overall health? Do they have any other medical problems that would affect their quality of life or particularly life expectancy? And keep those in mind, and bringing those up might be helpful for that discussion at that point in time. This deliberation may then result in a decision. That decision may be to yes, go ahead with PSA screening. It may involve no, declining the PSA screening test, or it may be the fact that the patient may need to decide after discussion with others. If that is the case, there's an opportunity to write a note here as to what the next steps might be. Finally, the decision aid allows for sharing of the discussion through either email or print by producing a PDF of the decision aid and all the notes and additions that were introduced in using it with each specific patient. This may serve also as a testimonial of the discussion, which may help with documentation in the medical record and for documentation with the patient in supporting discussions with their spouse or other clinicians. This concludes our demonstration of the PSA Choice Decision Aid.